Syncope definition: sudden and brief loss of consciousness associated with loss of posture tone from which recovery is spontaneous. Distinguishing syncope, dizziness, pre-syncope, and vertigo. No loss or loss of posture tone, drop attack, lead to fall without loss of consciousness, sometimes sign of uh, vertebrobasilar. TIA, 15% of cases, feature to distinguish syncope from seizure, prodromal, premonitory symptoms, precipitating events that follow it, precipitate prodromal symptoms, precipitated by pain, exercise, micturition, defecation, or stressful events, usually syncope, sweating, nausea, syncope, aura, seizure, disorientation, look more than 5 minutes, usually seizure rather than syncope. Important information: witnesses, initial assessment, special history will often lead to a clear diagnosis and help efficiently direct further work out and or treatment. H and B lead to identification of the cause in 45% of the patient. Differential diagnosis: neuronal mediated syncope, vasovagal, situational, carotid sinus, orthostatic hypotension 10%, psychiatric disorder 2%, neurological cardiac syncope, organic heart disease, arrhythmias unknown in 34% of the patients, neural mediated based or tilt table studies. Cause of syncope according to sex and presence or absence of cardiovascular diseases in this table. Percentage: structural heart disease, presence of a structural heart disease, CAD, CHF, valvular heart disease, CHD is the most important risk factor for predicting the risk of this. The risk of this at 1 year, most arrhythmias are found in these patients. Here the hazard ratio for the outcome of a patient: death from any cause, myocardial infarction. Risk factor: predictor of arrhythmia, syncope, or cardiac death at 1 year. CHF, ventricular tachyarrhythmias, abnormal ECG, age more than 45 years, presence of two or more of these and associated with 10% incidence of syncope or cardiac death. Cardiac differential, cardiac syncope, look, often the brodor indicate outflow obstruction, arrhythmias, prolonged, either congenital or drug-induced, EV block, sinus node dysfunction, ventricular tachycardia, arrhythmogenic right ventricular dysplasia, supraventricular tachycardia, Wolff Parkinson White, neural mediated syncope, most common cause, vasovagal, situational, carotid sinus syncope, result from sudden reflex mediated hypotension and or bradycardia, triggered by various stretch, mechanoreceptor, carotid sinus, bladder, esophagus, respiratory tract, carotid sinus syncope, autonomic dysfunction, neural mediated syncope, pathophysiology, peripheral venous pooling, increase, cause sudden decrease in peripheral venous return, lead to cardiac hypercontractile state which activate a stretch receptor. A neural traffic increase to brain mimic severe hypertension and evoke paradoxical bradycardia and reduce in PVR. Orthostatic hypotension, decline of 20 mg Hz NBP from supine to standing. Supine HT common in these patients, elderly especially vulnerable, baroreceptor sensitivity decrease, cerebral blood flow decrease, renal sodium wasting increase, thrust response with aging, peripheral thrombocytic tone impairment, diabetic neuropathy, antihypertensive medication. Neurological causes, syncope, rare manifestation of cerebrovascular disease, subclavian steal syndrome, basilar artery migraine, syncope, vertebro-basilar insufficiency, through attack, diagnostic evaluation. 45% of time can identify cause. ECG low yield but can be important. Clues to look for underlying heart disease. CT head, EEG low yield, echocardiogram, stress test helpful when presence of underlying cardiac disease can't be determined clinically. History, time of day, activity, preceding and predominance, associated symptoms, duration, injuries, medication, ingestion, cardiac history, family history, sudden unexplained disease, death, sudden unexplained death, deafness, arrhythmias, congenital heart disease, seizure, metabolic disorder, myocardial infarction, physical exam, pulse, blood pressure, taking spoon and standing after 15 minutes, murmur, click of outflow, tract obstruction, urological examination, carotid massage, arrhythmias test, telemetry, hotter, 12 to 24-hour symptoms, arrhythmias, external loop recorder can wear for weeks to months, implantable loop recorder, monitor for 20 to 18 months, provide diagnosis in 50% of patients with unexplained syncope compared to conventional method. AB studies helpful with structural heart disease. Tilt table test used to evaluate the autonomic nervous system, evaluate predisposing to neural mediated syncope, the specificity of negative test 90%. Indication for tilt table testing, unexplained recurrent syncope, single episode associated with injury or in setting that pose a high risk of injury. If organic heart disease is present, then after cardiac cause have been excluded. Evaluation of recurrent syncope in setting of autonomic failure. Assessment of recurrent unexplained fall. Indication for hospital admission. History of CAD, CHF, ventricular arrhythmia, accompanying chest pain, abnormal ECG, moderate to severe orthostatic hypotension, age more than 70 years, resulting trauma. Management of neural mediated syncope, patient instruction, preventing syncope or vasovagal spells, maintain adequate hydration and food intake, avoid drugs that lead to hypotension, avoid activities that precipitate syncope, preventing knock or injury, assume spine position upon onset of prodrome, avoid driving or other activities that could lead to injury.